Hi guys, okay, let's get started. So today I'm going to talk about tubular interstitial nephritis. If we say tubular interstitial nephritis, that is kind of interchangeable to interstitial nephritis. But for pathologists, precisely speaking, this is TIN, tubular interstitial nephritis. That means we do see the inflammation both in tubules and also interstitial areas. Okay. So I'm going to talk about the first general stuff, which is definition and etiology, mechanism, and histology. And second, I will give the summary of the several diseases, including drug-induced TIN, tubular interstitial nephritis, and infectious tubular interstitial nephritis, and also checkpoint inhibitor-induced TIN, and also TINU, tubular interstitial nephritis with uveitis, and also IGF-4-related kidney disease. So, tubular interstitial nephritis. This is very important. We need to distinguish these two stuff. One is acute and active lesion, and also chronic or inactive lesion. Because active lesion is reversible, and often this is an indication of the treatment. And also second, the chronic stuff is irreversible and inactive, so there's no indication of the treatment like steroid. So active lesions have mainly three things. First, tubulitis, which is leukocytes with epithelial layer of non-atrophic tubules. This is important. It's in non-atrophic tubules. Okay, and also second, interstitial inflammation in non-fibrotic areas. Third thing is interstitial edema. Interstitial edema is often, this is kind of very important because sometimes a patient has really minimal inflammation, but still we do see a prominent edema. We think of it, here's something weird. Then we need to go deeper, or we need to look at the other tissue. Then eventually, often we can find out the inflammation. If we see the edema, which is abnormal or kind of warning sign. So this is the example of the active lesion. You see, here is the tubule having lots of lymphocytes or monocytes. Tubular basement membrane, it's not wrinkled, which is not atrophic. But these tubules, these are kind of wrinkled TBM, so it could be atrophic, but this is still okay. So this is a non-atrophic tubule having lots of inflammation. This is active lesion. And also, we do see the lots of inflammation in interstitial area without fibrosis. Here, a little bit of fibrosis, which is not the active lesion, but here, this tubule has still intact or well-oriented tubular basement membrane, like wrinkled basement membrane. This is not the atrophic tubule having lots of inflammatory cells. And also, here is a mitotic figure. So this is active lesion. Tubulitis in non-atrophic tubule, and also inflammation in non-fibrotic area, and also a little bit of edema here. This is another example. You see the edematous interstitial area, and you see the lymphocytes and also plasma cells. And here, inflammatory cells and a little bit of edema again. So chronic lesions, there are two things. One is tubulitis in atrophic tubules, and second thing is interstitial inflammation in fibrotic areas. So this is kind of opposite, so active lesions seen in the non-atrophic and non-fibrotic, but chronic lesion is seen in atrophic and also fibrotic areas. So this is an example. You see there are lots of fibrosis in interstitium and tubules having wrinkled tubular basement membranes, so which means atrophic. Okay, and you see the inflammatory cells in the fibrotic interstitial areas, but this is chronic lesion, so this is not active. And here you see the pink stuff, which is fibrosis, and you see some inflammation here. And this is tubulitis in atrophic tubule. You see there are lots of lymphocytes in wrinkled tubules having wrinkled tubular basement membrane here, and also here as well. This is chronic lesion, not active. acute TIN etiology, you see the 70% of acute TIN is due to drug-induced process like allergic reaction again by the drug, lots of different drugs. And second thing is autoimmune process, and third thing is infectious TIN. The most common drug inducing the TIN, antibiotics, as you know, and the PPI, proton pump inhibitor, and also NSAIDs. Here are the list of the medications associated with TIN. There's so many stuff. We cannot remember all of them, but most of the most of the antibiotics can cause that. So we need to go literature and find out. And also we need to discuss with the clinician what kind of suspicious drugs patient is taking. And this is antibiotics, penicillins, and those things, cephalosporins, lots of things. And also antiretrovirals can cause that. And NSAIDs, COX-2 inhibitor, and others, 5-aminosalicylates, like, mesalazine and those things, and also GI protective stuff, PPI, proton pump inhibitors, and even ACE2 blockers, and antihypertensive, and ACE inhibitor, ARBs. More you can see chemotherapeutic agents and the diuretics and anticonvulsants and others like allopurinol is pretty much common. So here's the clinical findings of drug-induced TIN. As you can see, the triad of the drug-induced TIN is the fever and eosinophilia, a rash, but this is actually less than 50% of the cases. So this is not good sensitivity to detect drug-induced TINs. But the most common findings, actually, one of the most common findings is the microscopic hematuria. Again, but the hematuria is not specific also, and oliguria and mild proteinuria and the rising creatinine. So nothing is specific. So the important thing is we need to suspect that drug-induced TIN, whatever the patient, show clinical situation. So by histology, there is some trend for the location of the drug-induced TIN. Here, this is kidney tissue. This is medulla and the cortex and the capsule. So if the drug-induced TIN is very early stage, we often see the inflammation in corticomedullary junction. We don't know why we do see that in this area, but often we see it. I look at the textbook and papers, but there's no definitive information to explain this, location. So there are three things, the possible mechanisms for drug-induced TIN. This is from Heptin style. And first, allergic and hypersensitivity reaction. And this is not dose dependent, I can understand. And also, often this type of patient have eosinophilia. And second thing is immune complex deposition. In this entity, we do see IgG or C3 deposition in tubular basement membranes like NSAID. And the third thing is cell-mediated immunity, because we do see sometimes we see the granuloma, but this is kind of vague mechanisms. We cannot clearly tell this TIN is due to number 1 or number 2 or number 3. We cannot tell that because some patient has eosinophilia. Also, we do see granuloma and those things, So granulomatous TIN, if we actually often see the granuloma, any kind of, TINs. So actually granuloma is not the specific as well. Granuloma is famous for the like sarcoidosis or TB, but it's not specific. The most common one is drug-induced process. And also second one is sarcoidosis. The third one is idiopathic, which means we don't know anything. And other situation is granulomatosis with polyangiitis, Wegener's granulomatosis, and also foreign body reaction or BCZ bladder treatment, or xanthogranulomatous pyelonephritis, which is kind of severe infectious process. So again, granuloma is often seen in a TIN, but this is nothing. This is not specific for any kind of entity. So we need to look at everything. We need to check everything. Even we need to check the TB actually. So prognosis, usually drug-induced TIN responds to drug termination in 60 or 90%, and also responds within 1 to 12 months. But often irreversible with analgesics and NSAIDs, or especially if patient is taking that for long time. And the main strategy for the treatment is the drug termination plus steroid, giving the better prognosis. Adverse prognostic factors include severe tubular atrophy and severe interstitial inflammation, and granuloma, particularly for the granulomatous TIN, 50% cases are irreversible. Probably that is a kind of severe TIN. So drug-induced versus infectious TIN. This is often important for us to distinguish two etiologies because the treatment is completely opposite, Drug-induced TIN often shows eosinophils in tissue. However, not always we do see the eosinophils. Often, clearly, this patient is a drug-induced TIN, but we often do not see eosinophilia in the tissue. Also, we do not see the eosinophilia in the blood as well. That means drug-induced TIN cannot be excluded even without eosinophils in tissue. In the infectious process like pyelonephritis, often we see the neutrophils in interstitium and or tubular lumina. That's why the clinical correlation like medication use and lab data, those things are very essential. This is an example of the severe drug-induced TIN. As you can see, you see the inflammatory cells, and mainly these are eosinophils in interstitium, and also some edema here everywhere. And this is the higher magnification. You see the eosinophilic granules in the cytoplasm. These are eosinophils. This is another area. You see the tubulitis. You see the lymphocytes within the layer of the tubular epithelial cells, and also you see the eosinophils. But glomerulus is usually intact. We do not see the inflammation in the glomeruli because the main foci of the inflammation is the interstitial area or tubular interstitial area. So this area shows a very severe tubulitis with lymphocytes as well as the eosinophils here. And this is TBM, tubular basement membrane, and epithelial cell nuclei, and lots of lymphocytes and eosinophils. So this is an example of the infectious TIN, like pyelonephritis. You see the kind of very dirty stuff in tubular lumina, having lots of neutrophils. And also you see the neutrophils in interstitial areas as well. And and edema. You can easily imagine that this type of patient cannot be treated with steroid. That will kill the patient. So here's another area having lots of neutrophils, kind of hugging tubular epithelial cells, and also tubular lumina having lots of dirty stuff or debris or neutrophils. This is silver staining. You can see again lots of neutrophils having segmented or lobulated nuclei, which is feature of the neutrophils. This is another area, lots of necrotic debris in tubular lumina, right? And this area looks like granuloma. Even granuloma, it can be seen in an infectious process as well. So next entity is immune checkpoint inhibitor induced TIN. So there are two pathways for molecules or pathways for checkpoint inhibitor, immune checkpoint. So first one is PD-L1, PD-1, and the second one is B712 and CTLA4. So left panels showing the interaction between tumor cell and T cells. T cell is trying to kill the tumor cells by recognize the tumor antigen by with the T cell receptors. However, there is a kind of inhibitory signaling, which is PD-L1, PD-1. So tumor cell has some strategy to express PD-L1 to bind PD-1 to block this antigen presentation. However, checkpoint inhibitor block this inhibitory pathway. That's why T cells efficiently kill the tumor cell and causing the tumor cell death. The right panel showing the different one. This is the interaction between antigen presenting cells and inactive T cell to educate the inactive T cell eventually to kill the tumor cell. Here, antigen presenting cells is trying to present tumor antigen with MHC molecule, which is recognized by TCR, T cell receptor on inactive T cell. But again, there is some kind of inhibitory signaling, which is B71, B72, CTLA4. But checkpoint inhibitor blocks this pathway, then efficiently T cells is activated, then eventually kill the tumor cells. So, but we know that there's some side effect or immunotoxicity of the checkpoint inhibitors. The most common one is colitis. These are all kind of inflammatory disease. First one is colitis, 12%, and rash, 11%, and pneumonitis, 5%, hepatitis, and thyroiditis, and tubular nephritis, which is seen usually 2% of the patients taking the checkpoint inhibitors. So here's a report, 13 cases. 2.2% of all patients with CPI, checkpoint inhibitors, developed the TIN. Onset was about 90 days after CPI started, ranging from 21 days to 245 days. Pyuria is seen in 62% patient, and proteinuria, which is actually mild, is seen some patient, and 0.5 gram per gram creatinine, ranging from 0.1, which is normal, to 1.0 gram. And rising creatinine, a mean is 4.5 milligram per deciliter. CPI-induced TIN responded to steroids and all recovered in this paper. But some cases recurs after re-challenge with CPI. Here's an example of the CPI-induced TIN. By histology, we cannot tell, oh, this is a CPI-induced TIN. There is no specific histologic finding, so we need the clinical information. You see there's some inflammation in here and here. The higher magnification, a little bit, you see the granuloma here, which is cluster of the macrophage or histiocytes here as well. But we do not see the necrosis, which is very important. Because if we see the necrosis within the granuloma, that is indicated or suspect for the TB infection. Here's another area. You see some edema in the interstitial area and also some inflammatory, lymphocytic inflammation interstitial area. And some tubulitis here, lymphocytes within the tubular epithelial cell layer. Here, lots of inflammation, severe inflammation in interstitial area and also tubulitis here. Here you see the lymphocytes. Next, TIN, tubular interstitial nephritis with uveitis. This entity is also called Dobrin syndrome because Dr. Dobrin reported this entity in 1975. Median age of the onset is about 15-year-old, which is, kind of peace entity. And female-male ratio is about 3:1, and 100 cases have acute anterior uveitis, and 80% cases are bilateral. And this is very important. Only 21% cases proceeds, but 65 develop uveitis after renal signs. That means we need to pay attention for the uveitis even in patients having only TIN, right? So we need to tell the patient that you might have some visual disturbance or eye symptom. You need to call the doctor or hospital, right? So 90% cases we see the rising creatinine and 96% anemia and rising ESR 89% and increase the serum IgG 83% and eosinophilia only 17%. Proteinuria, low-grade proteinuria 86% and microscopic hematuria 42%. And eosinophilia in urine. Eosinophils in urine is very, very low. Pathogenesis is unknown. We don't know why uveitis and TIN. We don't know the common antigens. Whether there is a common antigen or not, we don't know that. But we assume that probably this is an autoimmune process like T-cell mediated inflammation. Minority follow some kind of viral infection like ED virus, and there is a report that some association with HLA like HLA-DRB101 or HLA-DQB1. This is an example. Again, only by kidney histology we cannot tell this is TINU. We need again the clinical information like patient has uveitis. Otherwise we cannot tell. So this is the kind of edematous interstitial area and also having severe interstitial inflammation. And some area, I believe, here is a tubulitis here and here. A little bit of higher magnification. Again, you see the inflammatory cells in interstitial area and the tubulitis here. You see the lymphocyte in this area here and also here. Importantly, glomeruli look okay. There's no inflammation in glomeruli. This is a high magnification. You see the lymphocyte here, and here as well. So this is tubulitis. And also this area is granuloma without necrosis and inflammation here. And this is the edema. This area is showing the more prominent edema in interstitium and a little bit of inflammatory cells and lymphocytes and also plasma cells here and tubulitis here. This is H&E staining. You see the severe interstitial inflammation again and also tubulitis. The last entity is IgG4 associated kidney disease. IgG4 associated kidney disease, IgG4 related kidney disease is the systemic disease, and 80% cases are male, and median age is about 65%, but it can be seen in a younger patient like 20-year-old. And 77% cases show progressive renal failure, and 83% cases have the other organs involved, commonly pancreas. Important thing is this lesion can be often detected as a local lesion or a nodular lesion. And often, in the kidney, there's some nodules by image studies, and clinician did or radiologist did the biopsy, then pathology report came back as IgA4 related kidney disease. 79% cases show the increased serum IgG4, and also 33% cases show the eosinophilia. Histology, this is the very important. 100% cases show the plasma cell-rich tubular interstitial nephritis. Actually, only this case, we can tell this is all IgG4-related kidney disease, because this is very prominent histologic findings. I will show later. And 83% cases showed IgG deposit in TBMs, tubular basement membranes. And importantly, 100 cases show the increased IgG4 positive plasma cells in the tissue. By definition, we need to check that this is the definition to call the IgG4 related kidney disease. So we need to have the more than 10 positive cells, positive plasma cells for IgG4 in hyperfield. This criteria is 100% sensitive and 92% specific. However, we need to exclude one entity, which is ANCA-associated glomerulonephritis or crescentic glomerulonephritis, because ANCA-associated crescentic GN often develop or often show the severe interstitial inflammation having more than 10 IgG4 positive plasma cells in the interstitial areas. We don't know why, but we need to exclude this entity. Some minority patients have the PLA2 receptor negative membranous nephropathy. This is the example. As you can see, very, very severe interstitial fibrosis. We called this is storyform pattern of interstitial fibrosis, like cuffing the tubules, as you can see. And this is lower magnification. And also you see the storyform pattern of the interstitial fibrosis. This is the silver staining. You see the storyform, but if you look at closely in between the fibers, we do see the lots of plasma cells. This is another area. You see the storyform pattern of interstitial fibrosis, and we do see the lots of plasma cells. This is another area. You see the lots of plasma cells. Also, we do see the lymphocytes as well. So this is the IgG4 immunohistochemistry. As you can see, lots of IgG4 positive plasma cells. Drug-induced TIN, we have never seen such many positive IgG4 positive plasma cells. This is really rare cells in a regular inflammation, but somehow in this entity, IgG4 related kidney disease, we do see the lots of IgG4 positive plasma cells. And this is the IgG immunofluorescence. As you can see, this is wrinkled or atrophic tubular basement membranes. You can see the IgG fine granular IgG staining on it. And also in an interstitium, we do see the kind of dusting type of IgG, weakly but diffusely. So if we see the lower magnification, you can see that this is TBM. Here, these are positive for IgG. However, we do see the lots of kind of faint or dusty IgG in all over the places. That's all. Any questions, you guys? Any other questions? Okay, if you don't have the question, we can finish. All right. Thank you. Thank you, guys. Have a good day.